Hi dear students, welcome to Ardent MDS. So now we have the recall questions of orthodontics from Neet MDS 2024. So let's dive into the questions. Question number 1. In the envelope of discrepancy in orthodontics, the outermost circle represents. So before answering this question, let us understand what is envelope of discrepancy, why such concept is being given. So this concept was put forth by Dr. Profit along with Ackerman to determine the range of orthodontic tooth movements. So the outermost circle constitutes the orthodontic surgery, right, as you can see in this picture. But let's understand the zones. So the innermost zone, okay, this zone is purely the range of tooth movement that can be accomplished only with the help of orthodontic treatment alone, meaning only by braces. So if you want to have more range of tooth movement, like I want to move the tooth more than 2 mm or up to 5 mm, then you have to go for the mechanics which involves the combination of orthodontics along with orthopedics. Okay. Now I am going to have a long range of tooth movement, like I am going to change the exact, or I am exactly going to change the facial appearance by means of surgery, means we have to go for orthodontic surgery. So when we see the last outermost zone, like if you want to accomplish the tooth movement of 10 mm backward or 15 mm ahead, we have no other option but to go for orthodontic surgery. But we do have one more intermediate green color zone between the surgery and orthopedics, that is with the help of TADs, nothing but temporary anchorage devices like skeletal anchorage systems or mini plates or mini implants, we can achieve the tooth movement greater than the orthopedics but lesser than the surgery. So that constitutes the green color zone. Now going back to the question, so in the envelope of discrepancy, the outermost zone, which is the outermost zone, this one, okay. So this constitutes the changes achievable by orthodontic surgery alone. I hope you guys are clear. Next, number 2 question. Two girls of 11-year-old. I will give a clue. When you see such a clinical question with respect to orthodontics, never ever forget to remember the age, because that age gives the clue regarding the treatment options. Yeah. Now, two girls, and again gender also is major importance because girls mature earlier than the boys. That's the general concept in growth and development. Now, diving back to the question, two girls of 11-year-old have come to orthodontist. The first one had attained menarche, while the second one is short in stature. Who is the ideal candidate for dentofacial orthopedics? Now, they have given the treatment modality like orthodontics or orthopedics. Now, it is dentofacial orthopedics. What is dentofacial orthopedics? The treatment modality which would involve myofunctional appliance or orthopedic appliance. That is the dentofacial orthopedics. Now let us see the types of clues that we have in this question. Now the gender, next age, now we have the treatment modality as well. Okay. Now let us see the options. First one, because early maturer and attain peak high velocity. First one, because late maturer and attain peak high velocity. Second one, because early maturer and yet attain peak high velocity. Second one, because late maturer and yet one attain peak high velocity. So the ideal patient for the dentofacial orthopedic is the one who are yet to attain the peak high velocity. Okay. So the patient who are at the stage of attaining peak high velocity, maximum changes can be accomplished with the help of dentofacial orthopedics, especially by means of myofunctional appliances, right. I hope you got the concept. So the answer for this question would be the second one, because they are late maturer and they are yet to attain peak high velocity. So this is the answer. Question number 3. Which of the following consider least stable? Okay, here is the clue. Which of the following procedures given below are considered least stable with respect to distraction osteogenesis? Distraction osteogenesis is a surgical modality used to widen the bones apart, or if you want to elongate the bone, okay, they will go for osteotomy and place a distractor. They will start to distract or separate the bony components apart by means of elongating the bones. So this can be accomplished either in the mandible or in maxilla as well, especially in case of patients who are having cleft palate, they will be having collapsed maxilla, and if that patient is amenable for expansion of the maxilla surgically, this section can be considered. But when it comes to stability, right, when it comes to treatment stability, option number 1, the widening of the maxilla are considered to be least stable after dissection osteogenesis. What is the reason behind that answer? Because maxilla has the circummaxillary fibers, lot of circummaxillary fibers and lot of mid-palatal fibers and sutures are there. So when we dissect the maxilla apart, those fibers tends to recoil the maxilla to the previous position. So that's why the dissection osteogenesis of the maxilla widening are considered to be least stable, right? Now, question number 4. Which of the following cephalometric landmark is drawn from tip of the nose and prominent part of the chin? So let us look back to various types of aesthetic planes in cephalometrics. So first one, E plane, nothing but Ricketts E plane. It was given by Robert Ricketts, it is also known as Ricketts E plane. Next we have Schiner's line, we have Burstone's line, we have Sushner's S2 line, and we do have Holdaway or also known as Harmony line. So let's see Ricketts line. Ricketts line is the line which is drawn from the tip of the nose to the most prominent part of the chin. That's the answer B, right, for this question. Let us also get ourselves exposed to other lines as well. Schiner's line, it was given by Cecil Schiner, right? So this line is drawn from prominent part of the chin to the S shape in the nose between the lips, okay, this region. So this line bisects the S shaped zone between the nose and the lips. So this is the S line, okay, whereas in case of E line, this line touches the most prominent part of the chin and the prominent part of the nose, whereas the S line, it doesn't come the prominent part of the nose but touches the S shaped design of the nose and prominent part of the chin. Then we have the Sushner's line, then we have the Burstone line. This line passes from the subnasal, this zone is called subnasal, and the prominent part of the chin. We have Sushner line which is passing from soft tissue nasal to soft tissue pogonian, and we have the Holdaway or Harmony line which is drawn tangential to the prominent part of the chin and the prominent part of the upper lip. Okay, so these are the various aesthetic lines we have to measure the facial harmony, and for this specific question, the answer for the cephalometric landmark which is drawn from tip of the nose and prominent part of the chin is nothing but Ricketts E line. Now, tip back bends. Okay, amongst the following options, which are the tip back bends? Okay, now when we see the options first order, second order, third order, we should go back to our knowledge that with respect to edgewise mechanics, we are having only 3 order bends. So definitely 4th order bend is not an option at all. Okay, let's focus on first order, second order and third order bends. Right. Now coming to first order bends, the first order bends are the one which changes the tooth in buccolingual direction. Meaning, if I want to move my premolar, okay, if I want to move my premolar labially, I have to give for first order bend. Now, question number 2, option number 2, second order bends, the bend which are incorporated to change the mesiodistal inclination. Okay, like I have my central incisors like this. Now, if I want to alter the mesiodistal inclinations of my teeth, then I have to go for second order bends. Then third order bends, if I want to change the buccolingual inclination of my roots, okay, that is called as torquing, I have to go for third order bends. Now, in this given image, we have tip back bends. What are tip back bends? Tip back bends are also known as anchor bends, predominantly used in Beck mechanotherapy, right? Yes. So, what does a tip back bend does to the teeth? Then we can understand what is actually happening to the teeth and inclinations. With respect to, we can match the answer. So, when this portion is called tip back, a straight line which is bent upward and inserted in the molar tube. So, what it does? This bend makes the crown of the molar to move distally and root of the molar to move mesially. So basically what is happening? The tip back bend is changing the mesiodistal angulation. Now we know that the second order bends are meant for changing the mesiodistal angulation of the teeth. So the tip back bends are nothing but the second order bends. Yeah? Yes. Now question number 6. Correction of sagittal position of the mandible is possible even after age of 11, but not in maxilla. Due to which parameter, right? The question is very simple and easy. The correction of sagittal position of the mandible. What is sagittal position? The anteroposterior position of the mandible is possible even after age of 11, but not in the maxilla. Why? The answer is cephalocaudal growth gradient. We know this is a basic concept in growth and development, that is cephalocaudal growth gradient. What does it say? The structures which are away from the pituitary grows longer duration of the time, whereas the structures which are closer to the hypophysis pituitary, they tends to grow and complete fast. So with respect to dentofacial complex, yeah, we have maxilla and mandible bone. Which one is closer to the pituitary? The maxilla. So the maxilla growth tends to complete first than the mandible. So since the mandible is away from the pituitary, it goes for the longer duration of the time. So the answer for this question is cephalocaudal growth gradient. We will also have some extra insights. What is foot and shoe effects? So when the width of the maxilla doesn't let the mandible to go forward, okay, meaning most of the class 2 division 1 patients will have retroposition mandible, and if we examine carefully, they might also have narrow maxilla as well due to various etiologies, right? When we incorporate the expansion of the maxilla in the treatment plan, there is something called auto-rotation of the mandible. The mandible would jump anteriorly to its position, okay? So when we expand the maxilla, mandible goes inside. This is similar to the shoe and the foot, okay? Wider the shoe, the comfortable the foot will set in place, okay? That implies the foot and shoe principle. Coming to safety valve mechanism, this implies the position of the canine in the maxilla, okay? This also the intercanine width in the maxilla with respect to guidance of the anteroposterior portion of the mandible, right? So option A and C is the relationship between the maxilla and mandible with respect to its width dimension, whereas with respect to the question, the answer cephalocaudal growth gradient implies that the mandible keeps growing longer period of time since it is away from the pituitary compared to the maxilla. So that's why the correction of sagittal position of the mandible is even possible at the age of 11, not in the maxilla. So pertaining to this question, the answer is B, okay, cephalocaudal growth gradient. Next easy question and most commonly asked question, okay, this is nothing but a space maintainer in the mandible, okay, and it is bilateral, okay. So obviously the option would be very easy. The option is lingual holding arch. So such kind of space maintainer are prescribed for the patient who had lost the premature exfoliation of the primary second molar, E, basically E. So this space maintainer restricts the mandible molar to move mesially. So this is nothing but a lingual holding arch. Coming to question number 8. A 10-year-old girl presents to an orthodontist with anterior crossbite. What would be the treatment of choice? So here the age is the only clue, okay, age is the only clue. So that for the 10-year-old patient, okay, for the 10-year-old patient, mostly the crossbite would be a developed crossbite, because what is a crossbite? When the lower incisor is ahead of the upper incisor, or to put in simple terms, when the patient has a reverse overjet, okay, and during at the age of 10, okay, the incisor would be either be completely developed or it must be nearing the completion of the development. So basically crossbites can occur either in the anterior region or posterior region, or it can be either developing crossbite or it can be developed crossbite. Since the age is 10, okay, since the age is 10, it is almost close to developed crossbite, right? Close to developed crossbite. But if in case of 6 or 7 years, it must be really developing crossbite. So for such patients, we have to go for a removable appliance called Catalan's appliance, which is basically cemented in the lower dentition, and this appliance is fabricated 45 degrees. Okay, so after having this appliance, when the patient bites over this appliance, the maxillary anterior dentition, which is in the crossbite, tends to move forward and bite gets corrected, right? So the answer for this question would be a Catalan's appliance. Obviously, the Hollis and label bow more or less are similar, and they retrocline the maxilla. So obviously, they are not at all an option. So the correct option for this question is Catalan's appliance. This is again an image based question in this exam. Malocclusion with maxillary arch crowding and posterior crossbite. This is what they have been asked. So the options are normal maxilla with constricted mandible, normal maxilla with expanded mandible, constricted maxilla with expanded mandible, normal maxilla with normal mandible. What could be the reason or the etiology for such kind of clinical presentation? So no, option D is strictly no. Had the maxilla been normal or mandible, this condition wouldn't have even happened. So option D is not the answer. Option A, malocclusion with maxillary arch constriction or crowding. Okay, in the question itself they have mentioned that there is a problem in the maxilla. So a maxilla cannot be normal as well. So option A and B is ruled out. Okay, so only remaining option is option C. Okay, so this is the right answer for this question, because the constricted maxilla along with the expanded mandible, when the mandible is wide or expanded, patient might have posterior crossbite. Yes, in question also they have mentioned posterior crossbite. Again, this is another clue where we can eliminate option A, because they have given constricted mandible. If the mandible is constricted, what would happen? Instead of crossbite, patient would have scissor bite. What is scissor bite? Buccal non-occlusion is called scissor bite. Okay, so the correct answer for this question is option C. Now, regarding to habits, sadomasochistic habit. What is this, sir? What is sadomasochism? It's basically derived from two terms, sadism and masochism. Okay, so such kind of habits are nothing but they are self-inflicting, deliberately harming and deriving pleasure out of it, but without any thought of committing suicide. Basically, this is a pleasure deriving habit which is self-inflicted. No other person does to us. It is self-inflicted for pleasure. Okay, and harming ourselves obviously, but no suicidal intervention. But in this exam, in the given options, the right option is frenal thrusting. I would say why. Option A, B, D, tongue thrusting, thumb sucking, mouth breathing. These habits are associated with some malocclusion. For example, the tongue thrusting would be associated with the patient who are having open bite or spaced dentition. If the patient is having complete spacing, tongue would thrust out of the dentition. They will be having tongue thrusting. The patient who are having the habit of thumb sucking, they will be having proclain dentition and consider maxillary arch. We always know that. Okay, and mouth breathing, because of either anatomical obstructions in the nasal airway pathway, patient will develop an habit. Okay, so these three are associated with either some anomalies or malocclusion, whereas frenal thrusting is also with malocclusion, can be of spacing the central incisors, but there are some literature saying frenal thrusting is also a rare component of sadomasochistic habit. Okay, so the better option for this question would be with this exam is option C, frenal thrusting. Coming to next question. One of the anthropometric measurements for assessing the growth of an individual. So there are two ways of assessing the growth. One is craniometric, other one is anthropometric. Craniometric are done in the dead skulls, basically dead skulls. Okay, whereas anthropometric are done in the living individual. Amongst the option lateral cephalogram, OPG, CBCD and soft tissue, the right answer would be lateral cephalogram, because of the reason number one, the growth can be quantified, meaning for example, if the patient is at the age of 10, I can take one lateral cephalogram, and at the age of 13, I can take another. At the age of 15, I can take another lateral cephalogram. At the age of 20, like I can take a periodically a lateral cephalogram, which is nothing but a radiographic technique, and I can always assess and quantify the growth. I can always say patient at the age of 10 was this much, the growth of the maxilla was this much, at the age of 15 it had grown this much, at the age of 20 it is up to this much. I can literally quantify the growth of the dentofacial complex with respect to lateral cephalogram. So this is the right answer. Okay. Now question number 12. Which of the following is the lingual orthodontic system? This is a bouncer question had happened in this NEET exam. So let us look into it. So please focus on the image. So in the first image, the one in the left side is nothing but traditional braces. What are they? Now the contemporarily the traditional braces is nothing but MBT system. Okay, MBT stands for McLaughlin, Bennett and Traversy. They have given the current contemporary, which is nothing but a edgewise. What kind of edgewise? Pre-adjusted edgewise system. Okay, they are given by MBT, the name of the authors, which is nothing but the appliances which are put on the labial or facial aspect of the dentition. Right. Coming to Damon. Damon is also a labial appliance given by Dr. Dwight Damon, marketed by Armco Corporation. Okay. Which is little different from the MBT in terms of ligation. They are nothing but the self ligation or passive self ligation to be precise. So these two images are label system. So in the question, option A and option C are out, right? Coming to insignia, right, and incognito. Okay, insignia and incognito come under the category of customized orthodontic brackets, meaning each and every bracket is being programmed for the patients. In case of this, in this MBT, brackets are already pre-programmed for the patients. They are not customized. They are all brackets pre-adjusted, but they are not customized for individual patients. Whereas in case of insignia and incognito, which are manufactured with the help of CAD/CAM, okay, computer aided designing and computer aided machining, they are manufactured for the specific and individual patients. The tip and torque are incorporated based upon the individual patient needs. Okay, so under this customized bracket system, insignia is label system, whereas incognito, marketed by 3M company, or lingual orthodontic system. Okay, so the answer for this question is incognito. Question number 13. This question is being asked from embryological development of growth and development of dentofacial complex. Yeah. So the question is, a completely mature newborn baby is having cleft lip. The question is cleft lip, and parents are asking for the reason. How do you explain this formation of cleft lip? Like, not if anything is like if there is a cleft, there should be a problem in the fusion of the facial prominence. Like we have a lot of processes like frontonasal, medial and lateral nasal process. We also have frontonasal process. Okay, everything will fuse at the designated point of time to have a proper shape. If there is any non-fusion, okay, there comes a problem of cleft. Okay, so with respect to cleft lip, we always know that the maxillary lip is formed by fusion of medial nasal process and maxillary process. Okay, so the non-fusion of medial and maxillary nasal process. Okay, please see on the number 8. When there is a problem happening in this zone, that is a non-fusion of maxillary process and medial nasal process, patient would experience the formation of cleft lip. So the answer for this question is option C, that is non-fusion of medial nasal process and maxillary process. Question number 14. In class 2 malocclusion, functional appliance is given to advance the mandible, and its effect on the maxilla. I will read you the question again, or I will simplify the question. Basically, the patient is given functional appliance to advance the mandible, right? So mandible will obviously come forward, but it also has effect on the maxilla. The question doesn't include it, or the patient in this scenario, the patient doesn't have any orthopedic appliance. What are orthopedic appliance? Headgear, reversible headgear, or the orthopedic appliances. Okay, that would have effect on the maxilla, but in this scenario there is no such appliances being mentioned. Now they are asking what is the effect, or what is the name of the effect happening on the maxilla because of the functional appliance given in the mandible. Simple, right? Yes, the option is very simple. So when the mandible is being advanced with the help of functional appliances anteriorly, the soft tissues tend to stretch the maxilla backward. Okay, the dentofacial soft tissues has a retroclination effect on the maxilla. So amongst the orthopedic appliance, which appliance restricts the growth of the maxilla? The obvious option would be headgear. So the headgear effect, okay, it need not be given only with the help of headgear appliance, but it also gets experienced when the patient is having advancement appliance as well. Okay, so option for this question is headgear effect. Question number 15. Again, a clinical based scenario where I always say look for the clues in the question like age and growth parameter. Yeah, so 11-year-old patient, yes, done, the age is set, which means the patient is in growing stage. So no orthodontics, no orthognathic surgery. We have to pertain to the functional dentofacial orthopedics. Yeah, so 11-year-old patient who has proclined upper anterior, and they also given the class 2 division 1. So you also have class 2, you also have what type of malocclusion, and not only that, the mandible is short. Because of the short stature of the mandible had experienced downward and backward rotation of the mandible with presenting the open bite. Okay, so now you have two scenarios. One is proclined dentition, and we also have open bite. So now to simplify this question, this patient is growing patient. Okay, so we have to consider the functional appliance and orthopedic appliance. Yeah, done. Now what are the presentations patient have? One is patient has proclined dentition. Number 2, patient has open bite. Now how do we address this? So the proclined dentition can be addressed with the help of headgear, and it can also be addressed with the help of functional appliance, because the etiology of class 2 division 1, please remember, it can be either proclined maxilla or retroclined mandible, or it can be a combination of the both. Okay, so to this patient they didn't mention which is at the fault, which jaw is at the fault. So basically we have to go for a functional appliance with headgear. Okay, this gives a combination. But again, with respect to headgear, we are having high pull, okay, we are having low pull, we are having plain headgear. Okay, now amongst the three options, what we should choose? Now here we have to look for a super clue, that is the open bite. Okay, so the open bite could be, the etiology could be either the infra eruption of the incisors or supra eruption of the molar, could be the reason for the etiology. So with this regard, when we intrude the molars, okay, in this scenario, when we intrude the molars, what happens to the mandible? Mandible tend to auto rotate. Okay, that might improve the situation, right? So considering all this, the correct option for this question would be a functional appliance along with headgear is straightforward. And what type of headgear? The high pull headgear, because high pull headgear takes the anchorage from the parietal bone and it intrudes the molar inside. Okay, when the molar is being intruded above, the mandible also comes forward, and that would improve the open bite scenario. So the option for this question is functional appliance with high pull headgear. I hope the explanation was clear. Now coming to question number 16, that is freeway space. We always know what is the freeway space, especially with respect to prosthodontics. The vertical dimension at rest minus vertical dimension at maximal intercuspation is equal to freeway space, right? Now, and this freeway space has to be assessed between the premolars, right? Okay. Now, in what type of malocclusion does this freeway space is increased? That is the question. Now, let's look into class 2. The answer for this question is class 2 division 2. Let's see why this is the right answer. Okay, because when the patient has class 2 division 2, how do they present? They present having the retroclined central incisors. Okay, they do have retroclined central incisors. And class 2 division 2 patients, they have a something called a deep bite, because those patients have acute gonial angle. What is gonial angle? The angle between the ascending part of the ramus and body of the mandible, the gonial angle. When they have acute gonial angle, they will be also be having deep bite. Okay, so such patients, when they try to bring the mandible, okay, when they try to bring the mandible, they will have to travel a long path to have the inter-incisional relationship. Okay, in such cases, they should have a long pathway. Okay, and that time the freeway space increases. Okay, and generally there is a correlation between the gonial angle and increased freeway space. For the patient who are having acute gonial angle, they will have increased freeway space. That is one relationship. Number 2, with respect to the teeth, the patient who wants to bring the mandible forward, they will have to have a steep forward motion. Okay, that time the freeway space also increases. So the answer for this question is class 2 division 2. With respect to the relationship between the acute gonial angle freeway space, the class 3 malocclusion cannot be the answer, because they will be having a large gonial angle. Okay, for the patient who are having large gonial angle, they will have small freeway space. Okay, so please do remember, to simplify the explanation, the patient who are having acute gonial angle will have large freeway space, and the patient who are having class 2 division 2 malocclusion will have a acute gonial angle with deep bite. Yeah, so I hope the explanation was clear. Now the last question, which fibers leads to relapse in orthodontic tooth movement? So we are having a mixture of fibers, can be gingival and periodontal fibers. Before that, let us have the brief look into etiology of relapse. Okay, it can be either occlusal factors, or it can be due to supporting structures like periodontium, gingival fibers, or soft tissue, disharmony of soft tissue, or the patient who are having habit that is uncorrected. Okay, habit is also one of the etiology of malocclusion that has to be addressed first in certain cases. If the patient who are having retained habits, that might also cause for relapse. And post orthodontic treatment, if the patient is in growing stage, for example, if the patient is being treated with the dentofacial orthopedics and they are being unmonitored for the rest of their life, growth still happens up to age of 18, right? That might also cause relapse. Yeah. Now going back to the question, they are all fibers. Okay, they are all fibers, and with respect to fibers, we are having two groups of fibers, that is gingival fibers and periodontal fibers. Okay, but the one fiber belongs to gingival category, that is transseptal fibers. They are the major reason for the relapse, because those fibers run between the teeth, and if the tooth is being twisted upon or rotated, these fibers tends to recoil faster than anybody. Okay, they always recoil. What is recoiling? Coming back to the original position, and they bring back to the original position which was there before ortho treatment. So transseptal fibers are the main reason for the relapse of the orthodontic treatment. How we can prevent? By means of providing a permanent fixed lingual retainer, number 1. Number 2, there is a procedure called circumferential supracrustal fibrotomy. Circumferential supracrustal fibrotomy, and we also know the other name, it's called Edwards protocol, because it was given by Dr. Edward. So after correcting the rotations and after finishing the ortho treatment, we have to use the BP blade, specifically BP blade number 12, and we can just cut down the fibers, that is circumferential supracrustal fibrotomy, so that we can cut the fibers, especially transseptal fibers, thereby avoiding the recoiling of the fibers and thereby preventing the relapse. Yeah. So my dear fellows, these are the questions being asked in this NEET MDS 2024 examination. I hope the pattern and type of question being asked and also I hope the explanation was clear and how to approach the questions. Yeah, thank you so much.